Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Mr. Shehbaz Malik from the United Kingdom. Mr. Malik is a consultant orthopedic and sports surgeon with an interest in shoulder and knee reconstruction and replacement, and offers surgery for athletes as well. His practice revolves around Worcestershire and Birmingham. He's also the Educational Training Program Director for higher surgical trainees and residents in trauma and orthopedics in the West Midlands. Mr. Malik is also countrywide clinical service lead for trauma at Worcestershire Acute Hospitals NHS Trust. He's also the secretary for the Midland Knee Society and has a lot of interest in research and has published several book chapters and published over 50 peer-reviewed publications. He has a keen interest in quad tendon ACL reconstruction. So today it's my great honor to introduce you to Mr. Shehbaz Malik from the United Kingdom. Over to you, Shehbaz.
Thank you, Hitesh, for the kind introduction, and Loy as well for the invitation to talk about the ACL reconstruction with quad tendon and why is quad tendon graft promising. As Hitesh mentioned, my name is Shehbaz. I'm a consultant in Worcestershire Acute Hospital Trust. I work in a number of different places around Worcestershire as well as Birmingham. These are my contact details. And I have no relevant disclosures in relation to this talk. So quad tendon is not something new. It dates back to 1979 when Marshall first described its use. In 1984, both talked about quad tendon in relation with the bone block. And it was then published with long-term outcomes in 1988. It wasn't until 1995 really when Fulkerson talked about central quad tendon technique. He then talked about the outcome of 29 soft tissue quad tendon ACL reconstructions with 2 revisions in 2003. In 2007, he described quad tendon being a reliable, pain-free, low morbidity alternative to ACL reconstruction. So it does have a long history. Well, quad tendon is more familiar than we sometimes believe. For those of us who do knee replacements, it's right there. We see it every other day or every week. Quad tendon rupture, we come across it frequently, and we also see it there. So it's not that unfamiliar for most of us. In terms of its anatomy, it's a trilaminar structure with superficial, middle, and deep layers. Its length varies between 6 to 8 centimeters with average width up to 3 centimeters. What's interesting is that its depth is 8 millimeter, and that's twice as thick as BTB tendon. In terms of its anatomy and layers, it consists of 3 layers, with the first layer being rectus femoris and a oblique fascial bursal layer that comes from the vastus lateralis and goes towards the medial aspect of the patella. And you will encounter this when you're doing the harvest, and often needs clearing out in order for you to see the very distal pole or a distal aspect of the quad tendon as well as the proximal pole of the patella. Second layer consists of VM and VL, and fibers come and blend in cross section in crossing pattern towards the distal pole of the patella. And the third layer is vastus intermedius, which is a homogeneous structure coursing in a parallel direction to the tendon. In terms of biomechanics, full thickness 10 millimeter graft has ultimate load to failure almost twice as much as the BTB graft, and significantly higher than the native ACL. There's no difference according to the biomechanical studies in terms of partial or full thickness graft when it comes to the ultimate load to failure. In terms of fixation techniques, it's been tested with a number of different techniques here. And again, there was no difference in the soft tissue quad tendon fixation techniques when compared to the bone block. This is a paper that's come out recently, just looking at recent modern techniques of fixing with different suspensory devices. Just a word of caution that it is supported by the industry, and they were looking at comparing the biomechanics of suspensory techniques for soft tissue quads tendon in an in vitro model of ACL reconstruction. And they looked at tape reinforced onlay with whip stitches, luggage tag, and staggered technique. For me, what was interesting is in the last column is that ultimate load was very similar for at least 3 out of the 4, and in fact was higher than the native or comparable to the native ACL. They also looked at the cyclic elongation and tension loss, which I won't go into the details of. I'll move on to the harvest technique. If you are not used to it or you're new to it, then it's probably best to go with a vertical incision just to get a bit more of the exposure of the quads tendon and get your confidence. You can use a ruler to get your 10mm graft width. You can mark out where your trajectory is and where the graft is, where the tendon is heading, so you don't go into the VMO or the vastus lateralis, and you can do it with or without the bone block. And in fact, I think with this incision, it makes it easier to harvest the bone block as opposed to a transverse incision. Like I said, you can take the bone block, but I think recently people have gone away from the bone block and doing a lot more soft tissue. So I will now talk about my technique with the Quadtrac system, which I quite like, and I'll go through the steps with this system. So that's my setup. I don't use any tourniquet. I use 20 ml of 0.25% bupivacaine with adrenaline in anesthetic room at the harvest site as well as the portal sites. I use a side support foot roll and a sandbag. That's the tray that has pretty much all that we need. It has a Quadtrac handle, a guide track handle, track cutter blade that comes in 8, 10, and 12mm width, and a quad cutter. I'm going to just run through the video, which I hope you can see on the left. I take 1 finger breadth above the patella. Its incision size about 3 cm. You take the guide track handle to clear the soft tissues, and then use that to make sure that I'm on the tendon. That comes with a Q viewer retractor that goes on top and is paired with that, and you can get your retractors out. This is the track cutter blade handle. Again, your blades are placed on depending on which size you want to go for. And once you've got the tracks, I then tag the prox at the very distal end of the quads tendon with the suture, and then use dissecting scissors to free it. Once I've done that and make sure I've got enough length, I then use the quad cutter, make sure the Smith & Nephew sign in this case is facing up, and then check again before you cut. And if you feel you are shy of what length you want, then you can release a bit more with the scissors. So the view on the top right shows you the length once you've got the Q view retractor in place. On the top left, that's the guide track handle, and you can use that. If you don't have that, or you don't have this system, you can use Mitchell's or any other blunt instrument just to clear on top of the quad so you can see the tendon very clearly. At the bottom left picture, I've tagged it. I'm measuring on the bottom right to make sure I've got my length up to 7 centimeters before I cut with the cutter. So here I'm just showing you the technique of closing it. I use First Pass Mini with a tape, but you don't have to use the tape. You can use a suture. And I'm going to play the other video how it looks on the inside. So basically it's a crisscross pattern. I call it shoelace technique. And you just pass from one end to the other until you come all the way to the very distal end. And you just need your retractor, your assistant, to just use a Langenbeck to just give you the view. And just remember which suture you are using and crisscrossing. And at the end, you will have a picture which looks like the middle one. And when you pull on it, as I'm showing in the video on the right, that it will close the gap very nicely. And of course, you don't have to close the gap if it's partial. This is another Q view retractor placed in, and you can see that I've taken a partial thickness graft and there's no breach, there's no fluid coming through. So in this case, I have not closed this defect. So what, prepping it. So again, my technique of prepping is first I use a locking speed whip stitch. I then take my suspensory device, in this case is the ultra button, and I dock that with a locking stitch to the graft. Once I've done that, then I do a second locking speed whip stitch. I make sure my assistant is not pulling on the ultra button, because then it will cause gapping, which we don't want. And then once you've got your second, I'll throw in the second locking stitch for the ultra button. So for each locking speed whip, followed by a locking stitch for the ultra button, it acts as a rip stop. So in case there was any pulling, if you pull too hard on it, it will stop it from tearing it apart. And this is my third ultra button locking stitch. And it goes proximal to the locking speed whip. Following that, I just cut one side of the needle and tie the suture down. Just 2 or 3 throws, and then pass the needle up or down, whichever way you started it. Cut the needle off and cut off the tagging suture. And now you can use that suture to pull the graft up as well, should you wish to. And that looks fairly neat. And I've gone through various ways of securing that ultra button to the graft. And at the end, I've worked this out to be quite a smooth process that I can teach others quite nicely if they're assisting me. So this picture shows a suspensory on the top and a suspensory at the bottom. And the graft length that you can harvest, it always will be easily 7 or more than 7. And if you get less than 7, we'll talk about that. That's also manageable. So these are my initial preps, which were different to what I'm doing now. And the only challenge is that if you are making your whip stitches a lot of the time passing through the graft, then it can make the graft quite bulky. And you need to keep that in mind. So here we're just measuring now to see what size is the diameter. So this is 8.5 tunnels. We're just passing through that. It's a little bit tight, but it's good. This is 8, so very tight, and 9 is a bit loose. So 8.5, it's a good size. And you always get that with a size 10 blade. Just a word of caution that if you are going to, I would say that on the side of being slightly loose rather than tight, because it's less forgiving compared to your hamstring graft. So here we'll just go through how it's docked, and this is the empty wall. The empty wall sign, there's nothing there, is stuck on to the PCL. Just take your time to clear and see the wall. And I like to see the fibers of the PCL just to give me some guidance and making sure that there is not too much soft tissue in the way and debride the native ACL that's stuck onto the PCL more often, and see all the way to the back. I like to leave the stump as a guide. I take a 45-degree chondral pick and mark my point. I then visualize it with the anteromedial portal and adjust accordingly if I'm off. I like to go as far back as possible and as low. I put a guide wire through in deep flexion and then put a 4.5 reamer on top. And I look out for the length of the tunnel using the reamer to give me an idea even before I measure it. And in this case, this was 42 millimeters. Then I use an 8.5 reamer on top of the guide wire. And I will need to dock about 15 to 20 mils in there. I've got a good sized graft, so I can go up to 20. You only, to be honest, you can just dock 15 in there, that's fine. On the tibial side, I use an elbow aimer in reference with the anterior of the lateral meniscus, and in the stump, I get the guide wire out a little bit proud, and I then extend the knee to make sure that my trajectory is reasonable. If I'm out, then I'll adjust. Protect the wire and then ream with the 8.5 reamer. And here I need to make sure, and I do spend time cleaning around the stump, especially with the quads tendon, because that's its point of where it gets a bit of bottlenecked and gets stuck down. I do it from the inside, from outside in, and I do it at the mouth of the tunnel. Now we're reducing the endo button. So it went in, I've just pulled it out just to show, and I remind my assistant that don't pull too hard that it comes out of the skin, which it can do. And there's a mark there which tells me that the button should have come out and is flipped. And to check that, I'm just giving a gentle tug. And you can see the mark coming back, but the button isn't. So now we're pulling the graft through. And that's where it can be very challenging. So I use a probe sometimes just to lift the sutures up to give them a bit of encouragement. And if the graft is too tight, then you will find that you're pulling quite hard. So I've already marked my graft that's going to sit in the tunnel. So once it comes through, I'll be looking out for it that it's reached that point. Because no matter how hard you pull now, it will not go in any further. And I'll just debride a bit of soft tissue and do any other debris around the graft. I then cycle it and extend it to make sure there's no impingement before I leave, and to check that it doesn't need any notchplasty. So just to summarize some of the tips, you may have seen that the knee was flexed. So when you're harvesting the graft, make sure the knee is flexed because it's bringing the quads a little bit forward and easier to visualize. And do so when you decide to close the defect if you are taking a full thickness graft. Go with the vertical incision instead of horizontal if you're unfamiliar or you're just starting off. Make sure you clear all the fascial tissue so you can visualize the graft. No matter what system you use, you can just stick a scope in and just see the graft, see the quads tendon clearly before you harvest it. Mark it on the skin so you can put the camera in and just see where the graft, where the tendon is, and you can mark it on the skin and it will guide you so you don't go straight. Then clear the soft tissue around the tibial tunnel, both outside and inside. I take 2 Langen bags and get my assistant to show me the tunnel mouth, and then take a nibbler and just clean all the tissue to make sure that if the graft is 8, 8.5 to 9, then I don't want any soft tissue coming in the way. Likewise, on the inside, I do spend a bit of time that to make sure the graft has an easy passage. And I've started doing recently is that making the graft bullet shape, which means just cutting the corners of that rectangular edge so it has, again, a smooth passage through the tunnels. As I mentioned before, that if the graft is tight, it's less forgiving with its passage through the tunnel. So if you are deciding between 8.5 and 9 and it's really tight, but it goes through, I would take a 9 rather than 8.5. You don't want to have problems when you are reducing it. And again, lengthwise, if you've got 6 centimeter, it is less, it's more forgiving, to be honest, because you are using suspensory. So you don't need a long graft if using a fixed endo button on the femoral side. So 6 centimeter, you can get away very easily with suspensory on both sides. There are other systems as well. This is Carl Stoll's, which I've used. It's got a blade handle, and a cutter and a separator. This is just a 5mm separator, and that's the cutter. And I'll just quickly show you a video with that as well. So just visualizing, as I mentioned, with the camera to look at where the quads tendon is and ends, and using a 10mm blade. And it's got marking on it again to show you where you will, how long the length of the graft. And using a camera just to show you that we are right in the middle of the tendon, in the central portion of the quads, and we're not going into the VMO or the vastus lateralis. Once you got your rail tracks, you will then need a separator, and we can see that that graft length is up to 75 millimeters. And you just make sure you've got the rail tracks all the way through. So this. So in this video, we're just separating with a 5mm separator. And I find this to be a little bit challenging, because if you don't get the right 5 mils, then your graft will be thin. If you get too much, then it won't fit into the separator. So it can be a little bit fiddly. But if you get used to it, you get used to it. But I found this to be a little bit challenging with this instrumentation, which I don't have with the Quadtrac system. And then once you've got that, this is the cutter. Again, this can be done blindly. I'm just showing it with the camera just to ensure that I'm cutting the graft correctly and that I've got all of the graft at the very proximal end. And then once I've got everything in the cutter, then I can go ahead and cut. And then you pull, using the cutter, the graft outside and tag it and take it off from the proximal of the patella. So what are the pros and cons? So with quads tendon, the pros are that it does have a large cross-sectional area. You can use it as a split or a full thickness with or without the bone block. It has low donor side morbidity, low re-rupture tear, and it's got 20% more collagen. Cons, well, it can have a high learning curve, but I believe that's with the bone block, but not with the soft tissue. There's risk of patellar fracture with the bone block. Shorter graft, I'm not sure if is a disadvantage, but I think with the suspensory devices that we have nowadays, we can get away with short grafts, and there can be some extension strength loss and some quad weakness, and that's something you do need to look out for. What about the evidence? These are some of the papers. I mean, there's tons of papers now come out which show quads it's a reliable graft. This one looked at autograft with or without the bone block, showing comparable clinical outcomes. So there were 484 in the soft tissue and 243 in the bone block. And they found that both grafts were safe and viable options for ACL reconstruction with comparable clinical outcomes, complications, and revision rates. There's another paper by Darren Dissau from McMaster that also looked at the bone versus all soft tissue. They had a high number of patients, almost 1,500 in the bone block, but very few in the soft tissue. And the most common complication was the graft rupture, but no difference between the graft choices. What was interesting was that the bone block quads tendon patient demonstrated postoperative rotatory instability than the soft tissue. What about in pediatric population? Again, this paper by Darren Dissau from McMaster has looked in that, and they've just looked at the 600 patients in 14 studies with the graft failure of only 2.5%, with growth problems in only just about 0.5% of the patients. So they found that quad tendon autograft is associated with low rates of post-operative complications, including graft failure, growth issues in this active and high-risk patient population. So it's very reliable graft for even the pediatric population. So when I started using quads a lot, I was quite interested in finding out about how the soft tissue was, because a lot of the papers mixed the population between the soft tissue and the bone block. So we did a systematic review, which we presented at ISACOS in 2023. We looked at the functional outcomes and the complication profile in our review. And we had 3 RCTs, 3 prospective cohort, 8 retrospective, and 4 case series. There were 2,000 patients, half of which were quads tendon, and the mean follow-up was just under 2 years. So when we looked at the functional scores between the quad tendon and hamstring, there was no difference. The difference at 6 months did not maintain at 1 year. When we compared the quad tendon with BTB, again, there was no significant difference in the functional scores. And in fact, one of the studies showed higher lesion score for quad tendon patients. In quad tendon only case series, the IKD scores were excellent. We managed to do meta-analysis of the gold standard BTB versus quad tendon, and there was no difference in functional scores. What about the other outcomes? Well, there was less harvest site pain and more active passive knee flexion compared to hamstring with the quad tendon. However, the quad tendon did not provide more rapid recovery. There was no significant difference in return to sports, and only 1 RCT looked at the analgesia requirements, and it was less pain and analgesic consumption in immediate postoperative period with quad tendon when compared to hamstrings. What about the complications? Well, the complication and reoperation rates was similar, about 8%, with graft failure 3.5%, and cyclop only about 1.5%. Surprisingly, arthrofibrosis was just about 1%. And the commonest reason for reoperation was cyclop lesions and arthrofibrosis. Again, these numbers are very, very low. When we looked at the complication in the comparative study between the quad tendon versus hamstring tendon, there was no significant difference in graft failure or anterior knee pain, and kneeling also showed no significant difference. When we looked at quad tendon versus BTB, there was no significant difference in stiffness, instability, or failures, but there was a significant difference in anterior knee pain, with significantly higher anterior knee pain of 26% versus 4.5% with BTB. And again, with anterior numbness, it was almost half the patients in BTB group had anterior numbness versus only 1.5% in the patients with quad tendon. So what about its comparison to the other reviews? So graft failure was similar. Infection was very low with soft tissue quad tendon in our systematic review. Anterior knee pain overall was similar. Kneeling pain was again similar with very low overall donor side morbidity, which meant tenderness, numbness, pain, or irritation at the donor side. Just a reminder that all these other studies, of course, had a mixed population of soft tissue and bone block quad tendon group. So in conclusion, we found that ACL reconstruction with soft tissue quad tendon autograft in adult population had low complication rate, less anterior knee pain, and no significant difference in PROMs. We were lucky enough to get this published last year in OTSI and can be found there. Thanks very much for listening.
Thank you, Shehbaz. Shehbaz, you can stop sharing. Thank you, Shehbaz, for this wonderful talk and great surgical technique.
Thank you very much.
Shehbaz, let's take a few questions. Shehbaz, one of the concerns is the length of the quad tendon. Okay, so the reason I'm asking is we have viewers from different parts of the world watching this program, and sometimes this particular harvester is not available in their country, right?
Sure.
So technically, are we able to use a traditional tendon stripper to take the graft? You take the initial part, make the sizing proper, and then use a traditional tendon stripper. Is it technically possible?
I think, to be honest, you don't even need any tendon stripper. All you need, you can make a vertical incision, as I showed from one of the journals, and you can visualize the graft beautifully.
No, but then it's a bigger incision, right?
But yeah, true. But you can go I made 2.5 to 3 centimeter transverse, and you can go that longitudinally. You don't have to go bigger than that, because all you need to do is visualize the graft, and you can do so with, and you can do that with a transverse incision. If someone is not used to transverse, they can do longitudinal, because you've got camera that you can stick inside the incision and visualize which way the graft, which way the, I keep saying graft, which way the tendon is sitting, because what you don't want to do is veer into the muscle on either side. But to answer your question, you don't need any tendon stripper. I think when I learned initially, the way I learned was that I tagged the proximal lens, and all you can do is take a centimeter, just like when you do your LET. Just measure your 10 millimeters on either side at the distal end, and take your 11 blade and just make railroads yourself. And once you've done that, you can cut it off at the proximal of the patella, and use your dissecting scissors and cut within that width, and you'll get it easily a beautiful graft. The setup I've shown makes life a little bit easier, a little bit quicker, but you can do it without if you wish to. It's just that it gives you that good view. You always, you don't doubt yourself that you are going off the track, and you're always going to land in the central portion of the tendon. But if you are in a place where you don't have these facilities, you can easily work without it, just making a habit of visualizing it and going in that path.
Okay, one of the reasons why I asked is, in case you're using a traditional tendon stripper, is it technically possible? Is it going to go either ways? Because you're anyway seeing the direction of the tendon, right? So is the conventional tendon stripper going to cause more harm?
Yeah, I mean,
have you tried using a conventional tendon stripper?
No, because when you say conventional, do you mean same for the hamstring?
Hamstrings, yeah.
No, it won't work because
Won't work.
It won't work because you're trying to take a graft that is 8 millimeter anatomically thick to put it that tendon stripper. A, I've never tried it. B, I think it's challenging because I don't know.
You will have the tendon. So guys, I tried it before. I give it a try, just a cadaver lab. You will have the tendon itself. Okay. So once you put the stripper is less than 8 millimeter, let's say, for the hamstring stripper, even closed or open, the quadriceps tendon will be harmed. Okay, so will be this because it's thick. Most of my quads tendon are about 10 millimeter thick. That's too thick to use the quadriceps or to use the normal harvester. Great talk, Shahbaz. One of the tricks that you can use, you see that the double blade itself, just put some ink, mark it, okay, with the marker, and then you have your trail, okay, and put it in. You can, this is one of the tips, and you can switch the camera, put your camera at the end of your track, and so you can see which way you are going, right or left, as without harvesting or any muscles, so you stay on the track. One of the questions to you about the quads, would you tell your patients that the risk of stiffness or arthrophyrosis in such grafts is a touch higher when compared to other grafts?
Look, I mean, I've done a thorough review of the literature. Arthrophyrosis rate was only 1.3% in papers that we looked at. So I do warn them, but so far I haven't come across patients who've had arthrophyrosis. In fact, I've got a patient that I've seen who's got stiffness, lack of extension because of a BTB graft, which on the MRI, 5-6 years later, he's been struggling, is 13 millimeters, causing impingement, right? So that risk is there with any of these big grafts. But I think with quads tendon, the risk is there, but I don't think it's as much as it used to be. Maybe, I don't know. I'm not sure. With better clearance of the soft tissue, we are aware of it, and we're making sure that we're not leaving much remnants there.
I mean, the theory behind the a bit higher risk of arthroporosis is that collagen, the amount of collagen is the highest among quadriceps grafts. So the amount of collagen, when it's be higher, means that the risk of arthrofibrosis, one of the studies showed that might be higher, just a theory. But how would you balance between graft size and the patient? Would you measure on MRI the thickness of the graft, or would do you have certain measurements you do so to balance between the graft size and the patient itself?
Yeah, look, 20% more collagen, which I mentioned in the quads tendon, that is true. But you know, like I said, arthrofibrosis, the risk is there. But so far, I've had one patient where extension has been a problem more than anything else. That's quads weakness. So I think that was because of lack of input from the physio, and physio's not understanding it. In terms of sizing the with the MRI, I think again studies have shown that you don't need to do that. I think I'm a bit more wary of females. You know, reluctant to use for the females. Although we just looked at a review comparing the male and females for quads tendon in terms of outcomes, but not necessarily the quality of the tendon. So I'll be a little bit more worry about the females, maybe in their 30s or 40s, whether I want to use it in those populations, just because they may have a quad tendon which may not be as good, but I've got no way of proving that. So if I was to look at the MRI, I'd probably look at those. But then again, then I probably will just be happy doing a hamstring, which works very well for them. And again, with hamstrings, how many times have we done hamstrings in big guys and the hamstring is not as good? And you know, you get
Exactly.
you get disappointed. You think, well, this patient should have a very bulky hamstring, and I can get away with a semi-T only and do a quad, and it's a tiny one, and you end up taking both gracilis and the semi-T. And I've done a petite females with a very good quads, footballers especially. Sorry, the hamstring being very good as well. So it's deceptive.
That's true. This is one of the reasons that's why.
Loy and Shehbaz, what about use of quads in a multi-ligament as injured knee? For example, do you think a quads and the hamstrings can be taken from the same knee?
So if there's an MCL injury, I protect the hamstring. So I don't violate the hamstrings. If I have to reconstruct the hamstring, then I'll use an allograft. I leave the hamstrings unharmed. So I use a quads tendon. So definitely for my go-to for ACL in a multi-lig would be quads tendon. And I think it's sitting there is a good one to use. And I'll either use contralateral or allograft for the MCL.
But you wouldn't use both, right? You wouldn't use the quads as well as the hamstrings
from the same knee.
Yeah.
No, because I protect the hamstrings as, you know, for the MCL sort of restraint. So no, I personally wouldn't. But I know colleagues in my training on fellowships where have used it, and you know, they have used the quads and the hamstring to reconstruct the MCL, and the quads for the ACL. I don't know about you, Loy. What would you do? Would you protect the MCL?
No, I want good point, Hitesh. I won't touch the hamstrings. I will leave them alone. I would use either an allograft for the MCL if it's needed, or I started to harvest the peroneus longus for such cases. Yeah, so I will keep myself away from the knee. Just take a PL or allograft when it's available.
And Shehbaz, what is your take on the peroneus longus?
Yeah, I was looking at this number of studies that have come out and a review article which has shown it to be a good graft. I'm not sure whether there is any, like with all things with quads tendon, we worried about a number of things with the bone block, and one paper showed us there was a high complication rate and learning curve issues, and then we went to soft tissue. You know, then the techniques improved as well. So with the peroneal graft, I'm not sure whether there will be any issues with foot and ankle at some stage later on.
There are people who looked at it and they found that the long-term function is not affected.
Yeah.
And even though you take the longus, the rest of the longus is there, right? So you tenodesis with the peroneus brevis. So
you stitch it exactly to the
yeah, you
brevis.
do a tenodesis with the
Okay.
remaining peroneus brevis. So essentially, you're retaining the peroneus longus.
Yeah, look, I think again for multi-legs, that's another source of graft. So if you don't, again, in countries where the graft allografts are not available, are expensive, even in an NHS, these grafts are costing thousands of pounds. They're not cheap. If you can get what you can get from the patient, then that probably is the best option. So maybe I need to go and have a look in the lab and get myself familiar with the peroneus and see
What
how.
is the trend in the UK with respect to the peroneus and the quads?
I certainly don't think anyone is doing the peroneus at the moment, or if they are, I'm not aware of it. I don't think it's quite come into fashion yet here. I think 80% to 90% of the surgeons will be using hamstring. Yeah, because that's the trend, and that's why everyone is happy. Quads is on the rise. I think it's on the rise here, but again, probably not as much. So maybe in multi-league, people are going towards a little bit more. Maybe the surgeons recently going abroad for fellowships are coming back with that skill set and being a bit more happier using it. I think it's one of those as well, because if you are brought up in a certain way, then things work for you, then why change? And I think you stick to things that work well, and there's no need to change. But I think we talk about one graft doesn't fit everyone, so you do need to be a bit versatile. You do need to have a graft based on your patient, and you need to discuss all the risks and the merits of each graft choice. Yeah.
Great,
You
Shebaz.
can use it for
Now, any
primary and
more
riveting
questions?
cases. I mean, I shifted completely to quads. I do have a really great results with the quads, especially with the primary and riveting cases. So why I should go to other grafts, other choices when I have good results with the quads? That's the issue. I think that's it, Hitesh.
Okay, thank you, Shebaz. I think that's all the questions that we have for this session. Thank you for this wonderful talk, beautiful surgical technique, and I'm sure this is going to reach to a lot of people all over the world.
Thank you so much for hosting me. Thank you very much, both.
Bye-bye.
Bye-bye.
Thanks, Shabazz.